2 minutes and we will start. Okay, let's start. Good day, dear colleagues. Today we'll discuss during our lecture the term Rickets, or the other name for this disease Rickets, or in Russian it's term Rahit. But more useful term that you can find when you just observe Nelson textbooks of pediatrics or just some other general medical literature, you can find the term Rickets. And during this lecture I will use this term. First of all, let's discuss bibliography. As for Nelson textbooks of pediatrics, the 20 edition, you can observe chapter 51. If you have just 21st edition of Nelson textbooks of pediatrics, there are just chapters, but of course you can find it when you see the list of literature, or you can find it's in a chapters that discuss deficiency of some vitamins and microelements. Okay, Rickets. Rickets is the softening and weakening of bones in children, usually became of an extreme and prolonged vitamin D deficiency. Symptoms include bowed legs, stunted growth, bone pain, large forehead, and trouble sleeping. Complications may include bone fractures, muscle spasms, and abnormally curved spine or intellectual disability. Sometimes rickets are not rickets is not just isolated variants of disease. Rickets can be just in multi-complex when it's just marasmus, or when it's just severe hypertrophy or severe deficiency of microelements and just some the deficiency of calcium and vitamin D. That's all. Just when you examine a patient with rickets, you should pay attention to the other, organs and systems in order to fix some other symptoms of some other deficiency. Okay, rickets. Bone consists of a protein matrix called osteoid and mineral phase, principally composed of calcium and phosphate, mostly in the form of hydroxyapatite. Osteomalacia is present when there is an adequate mineralization of bone osteoid and occurs in children and adults. But rickets is a disease of growing bone that is caused by unmineralized matrix at the growth plates and occurs in children only before fusion of emphysizes. Because growth plate cartilage and osteoid continue to expand, but mineralization is inadequate and growth plate thickens. There is also an increase in the circumferences of the growth plate and the metaphysis, increasing bone width at the location of the growth plates and causing some of the classic clinical manifestations such as widening of the wrist and ankles. There is a general softening of the bone. Sorry for misprinting, it was just my mistake of the misprinting that causes them to bend easily when subject to force such as weight bearing or muscle pull. This softening leads to a variety of bone deformities. Although this problem was largely corrected through public health measures that provided children with adequate vitamin D, rickets remains a persistent problem in developed countries. But many cases still secondary to preventable nutritional vitamin D deficiency. It remains a significant problem in developing countries and may be secondary to nutritional vitamin D deficiency and inadequate intake of calcium. I will give you 1-2 minutes in order to fix some key points of this information, and you can then do prolong. Okay, let's continue. Etiology. The most common cause is vitamin D deficiency. Rickets, the same, vitamin D deficiency. It's better to just remember vitamin D deficiency, rickets. These can result from eating a diet without enough vitamin D, dark skin. Pay attention, dark skin is one of the etiological factors. Too little sun exposure, and it's important to think and to remember a little sun exposure in order to some cultures variants of the clothes in some Muslim country. The deficiency of vitamin D is a result of the special clothes for women, and it's better to remember about it. Exclusive breastfeeding without vitamin D supplementation, celiac disease, and certain genetic conditions. Other factors may include not enough calcium or phosphorus. The underlying mechanism involves insufficient calcification of the growth plate. Diagnosis is generally based on blood test finding a low calcium, low phosphorus, and high alkaline phosphatase together with X-rays. rickets occurs relatively commonly in the Middle East, Africa, and Asia. It's generally uncommon in the United States and Europe, except among certain minority groups. But to be honest, of course, a severe degree of rickets can be relatively commonly in the just Africa, Asia, and Middle East country, but just low degree, first degree of rickets can be found during the examination child, sometimes with hypertrophy. That's why it's better to remember when you see patient with dark skin or patient with some special diet. For example, patients with atopic dermatitis, we prescribe just special diet from them with variants when they avoid some products. That's why it can be the reason for just vitamin D deficiency also. It begins in childhood, typically between the age of 3 and 18 months old. Rates of disease are equal in males and females. Cases of what is believed to have been rickets have been described since the 1st century, and the condition was widespread in the Roman Empire. And the disease was common into the 20th century also. Early treatments included the use of cod liver oil. And my first slides was just the variants that can observe during the archaeologist working. Then we find some patient with just severe rickets. Okay, once again, to repeat, to summarize, etiology factors: vitamin D deficiency, diet without enough vitamin D, dark skin, little sun exposure, exclusive breastfeeding without vitamin D supplementation, celiac disease, certain genetic conditions, not enough calcium and phosphorus. Rickets occurs in the Middle East, Africa, and Asia country. We remember about the skin color. Uncommon in Europe and Northern America, but don't forget about some risk factors. Okay, it's better to fix. And once again, it begins in childhood, typically between the age of 3 18 months old. Rates of disease are equal in males and females. And it's just a history, it's better just to know, not to fix and remember. Okay. Once again, to summarize, classification of the causes of rickets. Nutritional primary rickets risk factors. Living in northern latitudes, of course, northern latitudes, it's just the deficiency of sun. Dark skin, it's just some variants when we have small production of vitamin D in skin. Decreased exposure to sunlight in some Asian children living in the UK, for example, or just variants when it's maternal vitamin D deficiency, diets low in calcium, phosphorus, and vitamin D, exclusive breastfeeding into late infancy or rarely toddlers on unsupervised dairy-free diets, microbiotic strict vegan diets, prolonged parenteral nutrition in infancy with an inadequate supply of parenteral calcium and phosphate. First group of risk factors, it's nutritional or primary rickets, it's first group of risk factors. Okay, intestinal malabsorption, small bowel enteropathy, for example, celiac disease, pancreatic insufficiency, cystic fibrosis, cholestatic liver disease, high phytic acids in diet, Um, the other group, defective production, it can be chronic liver disease, increased metabolism of vitamin D, enzyme induction by anticonvulsants, for example phenobarbital, or some variants of medication for patients with seizures will also can be the increasing metabolism. The other group of risk factors is defective production, hereditary type first vitamin D resistant, family hypophosphatemic rickets, chronic renal disease or Fanconi syndrome, and target organ resistance to one of the variants of vitamin D. It's hereditary vitamin D dependent rickets type 2. It's better to fix all risk factors. I will give you 2 minutes. Okay, once again, nutritional rickets, intestinal malabsorption, defective production of metabolites, increased metabolism, defective production, and target organ resistance. Okay. Why we discuss color of skin, why we discuss the area, just look at this, living in northern latitudes, dark skin, decreased exposure to sunlight. Why? Because the formation of active vitamin D have some steps. First of all, just sunlight in skin produce 7-dehydrocholesterol. After that, cholecalciferol, vitamin D3 in liver, and also dietary intake, vitamin D3 from fish and meat, and vitamin D2 from supplements. And liver with some ferments produce 25 hydroxyvitamin D3, and also in kidney just with the other ferments, 1-hydroxylase, and also in just using parathyroid hormone, also just have influence to this process, produce 1,25 dihydroxyvitamin D3. Hydroxyvitamin D free in liver, dihydroxyvitamin D3 in kidney. That's why some liver disease, some kidney disease can be the reason for vitamin D deficiency and for rickets. Some intestine disease or some problems with gastrointestinal tract, when it's problem with dietary intake, or some problems when they just they have some celiac or some malabsorption. It will be deficiency of vitamin D from products. And if we use sun protective cream, or just special clothes, or avoid sunlight, staying or home just because it's very hot degree temperature, or just it's very the opposite situation when it's very cold, they stay at home, just no sunlight. The deficiency of 7-dihydrocholesterol, and it will be the deficiency of vitamin D results. Sunlight stimulates skin cell to produce vitamin D3, which is then converted to vitamin D3. Our exposure to sunlight converts vitamin D3 to inactive products. Vitamin D has very little intrinsic biological activity and must undergo successive hydroxylations in order to act as a hormone. In liver, it is hydroxylated to 21st hydroxyvitamin D, which is transported to kidney to form 1,25 dihydroxyvitamin D or 24,25 dihydroxyvitamin D. 1,25 dihydroxyvitamin D is the most potent vitamin D metabolite. This 125 dihydroxyvitamin D in gastrointestinal tract just increase absorption of calcium and phosphate. That's why diet, sunlight, normal works of livers, kidneys and gastrointestinal tracts is just common factors to prevent vitamin D deficiency. One of the poor steps, or one of the variants when it's just when it's some problems with liver, some problems with deficiency of the sunlight, can be the reason of can be the risk factors for rickets. It's better to fix. You can draw, you can write, or you can use these small variants of formation of active vitamin D, but it's better to fix. I will give you 1-2 minutes. Okay, let's continue. The other variants of formation of vitamin D, sunlight, 7-dehydrocholesterol, free vitamin D free, circulation in liver, they hydrolyzed to 25 hydroxyvitamin D free, in kidney 25 and 1 25 dehydroxyvitamin D free, and in just dietary sources of vitamin D in intestine and blood circulation, D2 or D3 vitamin D, and parathyroid glands influence to kidney and kidney hydrolyzation, and the influence of vitamin D. To be honest, the receptors to vitamin D we can observe at all organs and systems, but the most maybe not common, but the most high influence of the vitamin D to the intestine. It increases absorption of calcium and phosphorus. To the bone, it increases bone mineralization. To the immune cells, induces differentiation. To the tumor microenvironment, inhibits proliferation, induces differentiation, and inhibits angiogenesis. That's why nowadays they pay a lot of attention to vitamin D. According to the most popular disease for maybe the last 2 years, COVID pneumonias, they discuss the results of influence of vitamin D, prophylactic variants, or just we discuss the influence of vitamin D to the tumor microenvironment. That's why it's better for all adults, it's better to know the level of glucose, the level of cholesterol in the blood, and also it's better to know the level of vitamin D3 in the blood, and it's in situation when you are in a deficiency condition, it's better to use just the adequate doses of vitamin D3, because sometimes some adults just take very just huge, it's just ununderstandable doses of vitamin D. Pay attention and just take adequate dose of vitamin D. Okay, the other variants of vitamin D influence with a lot of receptors, and they influence into the adipose tissue, muscle tissue, and activation, proliferation, migration of apoptosis also that decreased. Also, it's increased osteogenesis and viability, and it influence to the some cytokines and to the some cells, and it's anti-angiogenic, pro-atherogenic just influence. That's why rickets, it's not the just disease of just growing up organism, just we pay attention and use prophylactic doses. It's better to know that vitamin D have a huge influence to all organ and systems, because they have receptors in all organs and tissues, and also all cells have receptors to vitamin D. That's why it's better to remember. Of course, for students, you can, according to Rickets, you can remember these small variants of just pathogenesis, or these variants of pathogenesis, or this one. Just choose and just try to remember. Okay, clinical evaluation. Because the majority of children with rickets have a nutritional deficiency, the initial evaluation should focus on a dietary history, emphasizing intake of vitamin D and calcium. Most children in industrialized nations receive vitamin D from formula, fortified milk, or vitamin supplements. Along with the amount, the exact composition of the formula or milk is pertinent because rickets has occurred in children given products that are called milk, for example it's soy milk, but are deficient in vitamin D and or minerals. During the practical classes we will discuss some cases when we have some patients when they use oat milk, it's just some other variants, then it's just baking then they just not normal formula, just some soy milk or some coconut milk. That's why it's better to remember and try to avoid and try to fix these risk factors during the when you're taking the history information. Okay, cutaneous synthesis mediated by sunlight exposure is an important source of vitamin D. It is important to ask about time spent outside, sunscreen use and clothing, especially if there are maybe cultural reason for increased covering of the skin. Because winter sunlight is ineffective at stimulating cutaneous synthesis of vitamin D, the season is an additional consideration. Children with increased skin pigmentation are at increased risk for vitamin D deficiency because of decreased cutaneous synthesis. That's why dark color of the skin is risk factors. Very important when baby was born. If it was winter, it's a risk factors. If it was autumn, also the risk factors. That's why pay attention to the date of birth and try to analyze all information. Okay, cutaneous synthesis. Sunscreen, time spent outside, clothing, some cultural reason, it's better to fix. Okay. The presence of maternal risk factors for nutritional vitamin D deficiency, including diet and sun exposure, is an important consideration when a neonate or young infant has rachitic findings, especially if the infant is breastfed. Mom diet, mom clothes. We discussed some religion aspects of some clothes. Determining a child's intake of dairy products. The main dietary sources of calcium provides a general sense of calcium intake. High dietary fiber can interfere with calcium absorption. The child's medication use is relevant because certain medications such as anticonvulsants, phenobarbital, and phenytoin increase degradation of vitamin D, and aluminium-containing antocides interfere with absorption of phosphate. Medication, maternal risk factors, mother's diet, mother's just work, maybe she works at office from 7 a.m. to 7 p.m. and just avoid sun lights, or some other variants. Malabsorption of vitamin D is suggested by a history of liver or intestinal disease. Undiagnosed liver or intestinal disease should be suspected if the child has gastrointestinal symptoms, although occasionally rickets is the presenting complaint. History of liver or intestinal disease because it's a risk factors. Fat malabsorption is often associated with diarrhea or oily stools. and there may be signs or symptoms suggesting deficiencies of other fat-soluble vitamins. And we remember that soluble vitamins it's D, A, E, and K. And if it's fat malabsorption, we can during the examination fix diarrhea, oily stools, and the symptoms of deficiency other fat-soluble vitamins. History of renal disease like proteinuria, hematuria, urinary tract infection is an additional significant consideration given the importance of chronic kidney disease as a cause of rickets. We remember the just circle of vitamin D formation, and we remember that renal disease also may be the risk factors, and don't forget about them. Polyuria can occur in children with chronic kidney disease or Fanconi syndrome. Polyuria, proteinuria, hematuria, and some repetitive urinary tract infection can be the risk factors. Liver or intestinal disease, renal disease. 1 minute to fix. Okay. Family history. The family history is critical given the large number of genetic causes of rickets, although most of these causes are rare. Along with bone disease, it is important to inquire about leg deformities, difficulties with walking, or unexplained short stature, because some parents may be unaware of their diagnosis. Undiagnosed disease in mother is not unusually linked to hypophosphatemia. A history of unexplained sibling death during infancy may be present in the child with cystinosis, with most common cause of Fanconi syndrome in children. Fix some key points of family history. Physical examination. Children with rickets might have a history of dental caries, poor growth, delayed walking, badly ingrained pneumonia, and hypocalcemic symptoms. The physical examination focuses on detecting manifestations of rickets. It is important to observe the child's gait, auscultate the lungs to detect atelectasis of pneumonia, and plot a patient's growth. Alopecia suggests vitamin D dependent rickets type 2. Physical examination and fix some key points. Dental caries, poor growth, delayed walking, rattling gait, pneumonias, some auscultation findings, fix them.
Очень хорошо работает, если появилось.
Okay, clinical features of rickets. These slides are very important, that's why you should fix them. General appearance, failure to breathe, listlessness, protruding abdomen, muscle weakness, especially proximal fractures. Head, craniotabes, frontal bossing, delayed fontanel closure, delayed dentition, caries, craniosynostosis. Chest, rachitic rosary, Harrison groove, respiratory infections, and atelectasis. Back, scoliosis, kyphosis, lordosis. Extremities, enlargement of wrists and ankles, valgus of varus deformity, Wincept deformity, combination of valgus with deformity of one leg with varus deformity of the other leg, anterior bowing of tibia and femur, coxavara, leg pain. Hypocalcemic symptoms, tetany, seizures, stridor due to laryngeal spasm. Clinical features of rickets, general, head, chest, back, extremities, and hypocalcemic symptoms. One minute to fix. Okay, this is the variance. Broad wrists, look at this. Rosary beads, pigeon chest, frontal bossing, broad ankles. It's some variants of the clinical features of rickets. General head, chest, back, extremities, compensating syndromes. Broad wrist, rosary beads, pigeon chest, frontal bossing, broad ankles. Clinical manifestations. Most manifestations of rickets are as a result of skeletal changes. Craniotabes is a softening of the cranial bones and can be detected by applying pressure to the occiput or other parietal bones. The sensation is similar to the feel of pressing into a ping pong ball and then releasing. Just when you press ping pong ball, in Russian we have just the name of the symptoms, симптом мяча для пинг-понга, симптом фетровой шляпы, but it's normal to name it craniotabes. May also be secondary to osteogenesis imperfecta, hydrocephalus, and syphilis. It is normal finding in many newborns, especially near the suture lines, but it typically disappears within a few months of birth. If you remember that rickets starts from 3rd month to the 19th month. Just the that's why you can't find craniotabes at the during the examination of 6 months child. That's why pay attention to these symptoms. Whitening of the costochondral injunctions results in a rachitic rosary, which feels like a beads of a rosary as the examiner's fingers move along the costochondral junctions from rib to rib. Once again, rosary beads. From rib to rib, you can observe rosary beads. Growth plate widening is also responsible for the enlargement at the wrists and ankles. Ankles, look at them, wrists, and it's the results of growth plate widening. The horizontal depression along the lower anterior chest, known as Harrison groove, occurs from pulling of the softened ribs by the diaphragm during inspiration. Softening on the ribs also impairs air movement and predisposes patients to atelectasis and pneumonia. And also some risk factors, as the vitamin D deficiency can be the risk factors of just decreasing the immune system, because we remember that influence of vitamin D to some immune cells very huge. That's why some infection disease just not rare, for patients with rickets. There is some variation in the clinical presentation of rickets based on the etiology. Changes in the lower extremities tend to be the dominant feature in X-linked hypophosphatemic rickets. Symptoms secondary to hypocalcemia occur only in those forms of rickets associated with decreased serum calcium. The chief complaint in a child with rickets is quite variable. Many children present because of skeletal deformities, various others have difficulty walking to a combination of deformity and weakness. Other common presenting complaints include failure to breathe and symptomatic hypocalcemia. Okay. Protruding forehead, large head, the circumference of the head was large, curved humerus, kyphosis, curved radius and ulna, curved femur, curved tibia and fibula, enlarged epiphysis and ankle, protruding abdomen because of hypertony of muscle system, depressed ribs, pigeon chest, enlarged epiphysis and wrist, dental hypoplasia and postporn eruption of the teeth, Harrison groove or Harrison sulcus valve, rachitic rosary, craniotibus, white sutures, swelling in wrist and ankle joints, frontal bossing, and delayed closure of fontanelles. Just some clinical features of the rickets. Look at this, alopecia, just deformation of the bone, softness, rickets rosary, just deformation of the skull, normal legs, varus form, valgus forms, and this is just the other variants. Then it's childhood rickets, and they are not the same as adult osteomalacia. We have variation because this is a growing skeleton, and they have just deformation of enchondro tissue. That's why you should understand that it's not the same as an adult osteomalacia symptoms. Okay, laboratory tests. The initial laboratory tests in a child with rickets should include serum calcium, phosphorus, alkaline phosphatase, parathyroid hormone, PTH, 25-hydroxyvitamin D, 125-hydroxyvitamin D, creatinine, and electrolytes. It's better to fix. Urinalysis is useful for detecting the glucosuria and amino aciduria, positive dipstick for proteins in the Fanconi syndrome, and also the excretion of phosphates in urine. Also important laboratory test. Evaluation of urinary excretion of calcium, 24 hours collection for calcium or calcium creatinination. Is helpful if hereditary hypophosphatemic rickets with hypercalciuria or Fanconi syndrome is suspected. Direct measurement of other fat-soluble vitamins, we remember that it's A, E, and K, or indirect assessment of deficiency. Prothrombin time for vitamin K deficiency is appropriate if malabsorption is consideration. 1 minute to fix all laboratory tests. Once again, serum calcium, phosphorus, alkaline phosphatase, parathyroid hormone, 25-deoxyvitamin D, 125-deoxyvitamin D, creatinine, and electrolytes. Urinalysis, glucosuria and aminoaciduria, urinary extraction of calcium, and direct measurement of other fat-soluble vitamins, or just prothrombin time for vitamin K deficiency if you are just suspect. Okay, sorry for misreading. Laboratory findings. Hypocalcemia is a variable finding as a result of the actions of the elevated parathyroid hormones to increase the serum calcium concentration. The hypophosphatemia is caused by parathyroid hormone-induced renal losses to phosphate combined with a decrease in intestinal absorption. The wide variation in 125 deoxyvitamin D levels, low, normal, or high, is secondary to the regulation of renal 1-alpha deoxylase caused by concomitant hypophosphatemia and hyperparathyroidism. Because serum levels of 125 deoxyvitamin D are much lower than the levels of 25 deoxyvitamin D, even the low levels of 25 deoxyvitamin D, there are still often enough 25 deoxyvitamin D present to act as precursor for 125 deoxyvitamin D synthesis in the presence of an upregulated 1-alpha hydroxylase. The level of 125 deoxyvitamin D is only low when there is severe vitamin D deficiency. That's why we fix that we need to fix all variants, 25 deoxyvitamin D and 125 deoxyvitamin D. Some patients have a metabolic acidosis secondary to parathyroid hormone-induced renal bicarbonate wasting. There may also be generalized aminoaciduria. Radiology, X-ray tests. Rachitic changes are most easily visualized on posterior radiographs of the wrist. Although characteristic rachitic changes can be seen at other growth plates. Decreased calcification leads to thickening of the growth plate. The edge of metaphysis loses its sharp border, which is described as fraying. The edge of metaphysis changes from a convex ovate surface to a more concave surface. This change to a concave surface is termed cupping and is most easily seen at the distal ends of the radius ulna. The residing of the distal end of metaphysis corresponding to the clinical observation of thickened wrists and ankles, as well as the rachitic rosary. Overallergic features include coarse tuberculation of the diaphysis and generalized infection. 1 minute to fix some key points for radiology findings. Radiographs of the wrist in A, it's normal child, and B, child with rickets, metaphyseal, fraying, and capping of distal radius and ulna. They are not similar, just even soft tissue deformation. And why we have wrist? Because Rickets because of metaphyseal fraying and capping of the distal radius and ulna. Diagnosis and differential diagnosis. The diagnosis of nutritional vitamin D deficiency is based on the combination of the history of poor vitamin D intake and risk factors for decreased cutaneous synthesis, radiographic changes consistent with rickets, and typical laboratory findings. A normal parathyroid hormone level almost never occurs with vitamin D deficiency and suggests a primary phosphate disorder. This is variance when just we have type when it's vitamin D deficiency, they cause some laboratory findings and treatments. This is the Rickets-like disease. In Russian we name them рахитоподобные заболевания. It's the diagnosis for differentiation. I give it during this lecture like just I should only mention. They will describe it during our practical classes. Treatment. In Russian Federation we have special national program for vitamin D deficiency for child and adolescents in Russian Federation, treatment according to the dose of 25 hydroxyvitamin D in blood serum. This level, 20-33 nanograms per milliliters, the treat doses per month, it's 2000 international unit, 10-20. 3000 international units per month, then less than 10 nanograms per milliliters, 4000 international units per month. And 1 month after that we repeat the laboratory test and just see at the level of 25 hydroxyvitamin D. Prophylactic doses of vitamin D, its normal doses 6 months, 1000, 6, 12 months, 1000, 1 year, 3 year, 1.5 thousand international unit per day, 18 months, and for adults also 1000 international unit per day. And look at this, we don't need to just use extra doses or maybe stop vitamin D when it's then it's mixed feeding or it's formula feeding, or we don't stop it in summer period. Just all year, just we need prophylactic doses. As for United States recommendation, children with nutritional vitamin D deficiency should receive vitamin D in adequate and additional intake of calcium and phosphorus. There are 2 strategies for administration of vitamin D. Huge dose of vitamin D, stose therapy, intramuscular 2-4 doses over 1 day, or just stose therapy, in one moment. The alternative is daily high dose vitamin D with doses ranging from 2000 to 5000 international units per day, always for 6 weeks. Other strategy should be followed by daily vitamin D intake. Look at this, for United States prophylactic doses in 400. As for Russian Federation, prophylactic doses no less than 1000 and 600 for children 1 year and old. The other recommendation I can find in some European recommendation, nutritional rickets is managed by advice about balanced diet, correction of predisposing risk factors, and daily administration of vitamin D3, cholecalciferol. If compliance is an issue, a single oral high dose of vitamin D3 can be given, followed by a daily maintenance dose. Healing occurs 2-4 weeks and can be monitored from the lowering of alkaline phosphatase, increasing vitamin D levels, or healing on X-rays, but complete reversal of bone deformities may take years. Summary. Rickets nutritional has emerged in infants exclusively breastfed into late infancy. Diagnosis: serum calcium is low or normal, phosphorus low, plasma alkaline phosphatase greatly increased, 25-hydroxyvitamin D low, and parathyroid hormone elevated. X-rays features cupping and fraying of the metaphysis and widened epiphyseal plate. And vitamin D3, cholecalciferol, and vitamin D2 from plants and or yeast, biological equivalent, and characteristic that is fat-soluble vitamin D, and sources vitamin D hypercalcemia, some anorexia, pancreatitis, CNS effects, polyuria, nephrolithiasis, renal failure. That's why the adequate doses of vitamin D is very important for growing organism. Thank you for your attention. During this lecture we discuss all variants when it's vitamin D deficiency and some findings that we can observe during the examination of the child with vitamin D deficiency. At our practical classes we discuss all clinical manifestations and also pay more attention for differential diagnosis. Thank you for your attention. See you next lecture.